Welcome back to this session. To introduce the following moderator will be Dr. Zhang Hong. Dr. Zhang is the president of Taichung Armed Forces General Hospital. I now turn the floor over to Professor Zhang to introduce our keynote speaker. Professor Zhang, please.
Thank you, organizer. Today we are really lucky to have the world expert and leader in medical education. This young lady, full of the full compassion and unfailing support in National Defense Medical School education transformation. Today is my really honor to introduce Professor Li. Professor Li is a professor of medicine, special advisor for education innovation at Tufts Medical Center, and a member of the Fulbright Specialist Program from year 2015 to year 2020. During last year, this year, she was selected as the Kimitaka Kada Visiting Professor at the University of Tokyo's International Research Center for Medical Education. Dr. Li served as an associate provost across Tufts University, 10 schools and 3 campuses. Broad responsibility involved interdisciplinary educational and global health initiatives, include open education with partners in Asia and Africa. As a former dean for educational affairs in medicine, she was both the strategy and the operational leader. She brought e-learning, faculty development, and the major educational grants to Tufts University Medical Center starting in the early 1990s. Over the past 3 decades, she has focused on how innovations in leadership training, technology integration, and open access can transform professional education and global health. Under her leadership, major initiatives have included academic leadership development in Tufts University organizations, Center for Enhancement of Learning and Teachings, Tufts Open Course Welfare, and the USA One Health Core Competence Development, and the implementation of e-learning internationally. Dr. Li right now still remains on the board of governance at the Tufts Medical Centers. Today, he's gonna give us a talk regarding formatting and the competency-based assessment of clerkships. Ladies and gentlemen, let's give a round of applause. Welcome, Professor Li. Professor Li, please.
Thank you very much, Professor Zhang and President Sutu, for inviting me again to National Defense Medical Center. It's an honor to be here. I always enjoy coming to your medical center. It's just wonderful to see all of the progress that you've made, as visionary leaders of medical education here, and to see Professor Lai over many years, again, one of Taiwan's foremost leaders in medical education. It's really a privilege to come and speak to you today. So during this session, I was asked to talk about formative and competency-based clerkship assessment. And so, during this short time, I want to have us think about why do we assess, how do we address gaps in current educational training, and I'll be going through some definitions about competency milestones and what's called core and trustable professional activities, or EPAs. And this is something, I'm just curious, how many of you have heard of EPAs? Quite a few, actually. That's excellent. Okay, so, how can formative assessment and learning research aid student learning, and how we can integrate that assessment into teaching, research, and practice? So think about, why must we assess? You know, what's so important about assessment? So how many of you are faculty? How many in here of you are faculty? So the majority, how many students are still here? Handful of students. Or only a few of you are admitting that you're students. But you know, so most of you are faculty. So you think about the trainees. You, as faculty, you have both students and resident trainees working with you. And so what I'm going to have you think about in the next hour is how they are performing compared to how you think they should be performing, and what the difference is. And I want to try to pay attention to that. So while we're training our students and our residents, we need to remember that the ultimate goal is that we're trying to graduate doctors who are competent, caring, and who can practice independently. And when we think about our system, if you think about, gee, you know, my students really aren't performing the way I think they should, or the residents that we're getting, they're not performing exactly how, you know, we expect them to. We need to think about the fact that the system that we're currently using to train is giving us the products, the students and residents that we are now seeing. So if there is a gap, then we as faculty need to look at what we are doing that is perpetuating that gap. So I want you to think specifically, when you see your students on day one of your clerkships, and I guess in your system, clerkships start, is it year 4? Year 5? Year 5 is the first, you know, so they do 4 years, and then 5 and 6 are your 2 clerkship years. So on day 1 of year 5, and you know, you're getting ready for that new group of students to come in to start their clerkships, are they performing the way you expect them to? And I can tell you that about, you know, I'd say it's maybe about 15 years ago now, our clinical faculty in our hospitals were saying, medicine is changing, it's much faster, we do not have time to, you know, I think it was mentioned in the hour before, you know, doctors are so busy in your clinics, you know, you're doing procedures, you're running from one thing to the next. Our clinical faculty said, we don't have time to train the students. They need to come into clinic being ready to jump in and work on the team. And, you know, how can we do that? Because when I trained many decades ago, there was plenty of time for me as a medical student to just wander around and figure it out. There's no time for students to wander around and figure it out. They need to walk into day 1 of the clerkship and be ready to function as a productive member of a care team. So what that has meant is we have needed to really change the way we're training our medical students. So what are some training methods that can help bridge those gaps? You know, we had to undergo major changes over the last 10, 15 years. So one of today's main goals is I want you to consider different ways of training, and I know President Sutu and his very able staff and you as faculty, you have already implemented a lot of changes. And you know, each time I come here, you know, I know you've made tremendous progress in looking at different methods. And I'm hoping today maybe add some thoughts. You know, I know that you already have a very progressive curriculum, And so, this is a time to think about, well, where else can we make improvements and change? But, I know you already have a very strong program. So comparing training methods. So, here we go. So the traditional training method is very time-based. So it's a very set amount of time. You have your 4 years of pre-clerkships, your 2 years of clerkships, and then your post-grad years, and then your residency. It's all very time-based, and I have to say it's the same in the US. It is very time-based. Ours is 4 years of college, then 4 years of medical school, and then varying times for residency. A very standard curriculum that's given to all students. So you as faculty decide on the curriculum, you give the same curriculum to everybody. There's some exposure to patients in the clerkships with your standardized testing. And, but what we do notice, and we notice it in our programs as well, there's still variable outcomes, meaning that the students graduating at the different points in time, they do not all perform the same. So what has happened? So I'm going to talk a little bit about what some of these alternatives are, but before I get there, I want you to think about that first year clerkship student, beginning of year 5, and can someone describe to me a gap that they currently see? Something that, from some of you who've been teaching at least for a few years, and every year you say, gosh, here the students come again. And they still, every year, I expect them to know this, and they don't. So can someone just give me an example of something that's been annoying you that you expect them to know and they don't? I know that they're there because I get them from our own faculty. So, yes.
Some important points we teach taught at the class. We think that they must know, but they come to hospital and I'm puzzled why this important thing.
And can you give an example of one thing, just specifically?
I taught hypercalcemia in nephrology class, and I already taught them what the most important etiology of hypercalcemia. When the student come to the hospital and do teaching time, as I'm teaching, when I ask them this question, not every student knows the answer.
Okay.
Yeah.
So hypocalcemia? Hypercalcemia.
So I'm confused why this happened because I already told them several times.
Yes. So, keep that in mind. So, in the preclinical curriculum, hypercalcemia was taught multiple times. You'd expect after several repetitions, why do they still not remember that? Okay, that's one example. Someone give me another example. Yes?
I've done some research on the clerkship, so I found the clerks in their year 5, and they have some gaps between the school and the hospital. The first is they cannot integrate the knowledge they learned in the school, because in the school the curriculum is disease-based or organ-based, but in clinical they meet the patient with different symptoms and signs, so they don't know how to make a clinical reasoning process and the differential diagnosis, and how to integrate their knowledge into the clinical situation. And this is the first. The second is they have too little time to work in or study in the hospital. They always study in the classroom, so they don't know how to be part of the therapeutic team, work with the team.
Yes.
So they are always in the outside of the team. So they are just watch, and the doctors and the interns or the residents are too busy to care about these students. So they don't know what this group is doing to the patients. So they think they are outside of the therapeutic team. Yeah. I think there's a major gaps.
Yeah, so that's a very interesting point, in terms of classroom learning in the first 4 years, and then they have to make the transition to team-based learning and clinical application of their learning. I'll never forget, this is actually at the intern level, a beginning intern was working with me in the clinic and came to me very upset that the patient did not have a diagnosis. And I reminded the intern that that's why they actually come to clinic. But they were so used to having patients as students where they already knew the diagnosis, and then they were working on some other aspect of the patient care. So there's a gap between book knowledge, classroom knowledge, and clinical application, and the ability to integrate. So, I think we should keep these examples in mind. So, why is it important that we identify these gaps? So what's the consequence of that gap? The fact that they're having difficulty integrating. So what's the consequence? Why is that important? Why do we need to worry about that? Yes?
Because I have research, so I teach the students the aesthetic idea and the technique in the class. And we also teach them in the OSCE. But actually, when they are doing the patient care, they still kind of add a lot of things. So the consequence of the gap, the idea of aesthetic and the clinical gap is, if they do the thing wrong, the patient will get infection and other complications. Yes.
Yeah, so there is a very real clinical consequence, potential patient harm from there being a gap between what they should know, what they're competent in, and what they actually can do. Yeah. And so this leads us to think about, well, what is our current training? How can we change the way we train in order to close those gaps? So one of the ways, I listed here, this is just one path, but something for you to consider. And I think many of the U.S. schools are moving this way, and I have to say, U.S. medical schools are being pushed by our accreditation. And if you think that the U.S. schools are so progressive, they wouldn't change if it wasn't for the accreditation push. And so for us, we have what's called LCME accreditation, and it's getting more and more strict. And they, as part of the evaluation of the medical school, they are looking to see whether or not we have true competency-based training. So this is something that the U.S. medical schools have really been pushing. So it's less time-based, although we still, all the schools at the moment still have the 4-year structure, but there are schools that are starting to move to what's called mastery-based learning. So as you define specific competencies, students can actually move through the curriculum at different paces. And so moving to a more individualized curriculum, so rather than all the students sitting in a classroom together, things are actually more individualized so that they can learn, typically in small groups, and then they get constantly tested in specific competencies. So there's an emphasis on mastery with many different assessment methods. So it's not just paper pencil, or now it's computer-based exams, but there's a lot of hands-on testing. And testing as an individual with simulation, testing in teams, make sure that they can function on a team. And this is happening throughout the 4 years. We're not waiting for the third-year clerkships anymore. This starts from day one. And so we're not there yet, but we're pushing for much more uniform learning outcomes. And our accreditation system actually requires us to provide proof that we are getting more uniform learning outcomes. So they want to see all of our competencies, all of our curricular methods, multiple assessment methods of every single competency. So we can't say we're just testing by simulation for this competency. Each competency has to be assessed in multiple ways, so that reinforcement is really there. So how many of you have heard of CPAR? You've heard of EPAs, some of you. So a couple of you have heard of CPAR. So this is important because I know that Taiwan likes to send a lot of your residents to the US and Canada for residencies. And this is going to be very important for you because this is now becoming a requirement. It's not 100% required yet, it's strongly suggested, but it's getting there quickly. They're giving all the schools time to catch up. But the ACGME, this is the Accrediting Council for Graduate Medical Education, these are for the residencies, they have defined what are called core and trustable professional activities for entering residency. And what this means is that every medical school student graduating from US medical schools, when they enter any residency in the US, regardless of specialty, they need to have passed competencies in all of these what are called core EPAs. And they're common across all specialties, doesn't matter what specialty they've applied to. And so what that means is that if the graduates all need to have these, that means that the medical schools need to pay attention to this and make sure that they're teaching to these core EPAs to prepare them so that they can enter these residencies meeting this standard. So you have the ACGME for the residency level, and we have the LCME for the medical school level. And that's where the connection is, because in order for our medical schools to meet this standard, LCME is changing its standards of evaluating medical schools at the same time that ACGME is changing its assessment of residency programs. And then for you here in Taiwan, that affects your students and residents who are going after ECFMG certification effective 2023. And that's one of the reasons why I think this is quite important to you as a medical training center. And so here are some definitions, and I don't know if people got the PDF, so you have copies of this. But I just wanted to make sure that I had the definitions for you, something for you to refer back to for those of you who are not familiar. But it's basically a discrete clinical activity that requires the use and integration of various competencies that typically involve some patient risk. So it's a little different than just a simple competency. This is really the integration piece. It's not just a single, can you tell me what hypercalcemia is? But it may be at a residency level, evaluation of someone with pituitary dysfunction or whatever, where they're going to need to integrate a lot of knowledge, various knowledge, in order to actually take care of the patient. So here, a supervisor must assess learner skills and allocate a level of responsibility that corresponds to the level of trust in the learner's performance. Are you able to trust the learner to perform on their own? And that's something that's really key, moving from the student level to the residency level. In the US system, the intern is legally a doctor and can prescribe medication, write prescriptions, etc. And so they need to be competent in independent practice, even though obviously they're still in training, there's still oversight. But there are certain things that we expect an intern to do that we can trust them to perform on their own. At a student level, it's much simpler, things like inserting in an IV or providing patient education. It's up to you and your curriculum to decide, what's appropriate for your level of student. So here, again, I provide some definitions so that you have them available to you. And the competency, what's interesting about competencies is that this is something that's been around for decades and in the education literature for decades, but it's finally gelling in the medical education arena because it took a long time to figure it out. It's been in education, but how could we really apply it to medical education? I can tell you, when some of these efforts started a couple decades ago, people were much too specific. The expression is, they forgot about the forest. They were looking at all the little trees, and when they were designing competencies, they were getting into much too much detail. And now we have much more experience with this, and we're defining broader competencies, which actually relate much better to clinical performance. And this has been done for every single specialty: pediatrics, OBGYN, medicine, surgery, etc. So that, I don't know where you are in your competency development, but there are a lot of resources out there. US schools, Canadian schools, European schools, and I think other schools in Asia are all, and I'm sure here as well in Taiwan, you're all working on competencies. Use the things that are out there. Don't try to reinvent it, because a lot of work's already been done. And the milestones are points along the continuum of competency, typically specialty specific and often given with what's called formative assessment. So, as an example, you have a novice, and say we can take this as maybe you're entering fifth-year student. So maybe one of the competencies is, think about one of the early teen behaviors that you expect. That they're able to round with the team, able to report, provide patient presentation to the team. You can think about what the specific competencies are, and then decide on what the milestone is for you to test every student at that level to see whether or not they meet that competency. And by the time you add competency after competency, you will finally reach in trustable professional activity, and this may be something as a graduating student, getting back to the core and trustable professional activities required for entering residency. So what EPA is required that is made up of multiple small competencies that you can be testing along the way with different milestones that leads up to an EPA. And I think, what this slide helps you remember is that the EPAs are really much more integrative. It's really requiring multiple competencies to make an EPA. What's formative feedback? And I think, I know you've had many faculty development workshops learning about formative feedback. And it's always good to remind ourselves, though, it's giving information to the learner to change their thinking or behavior for the purpose of improving their performance. So, and also not just improving their performance, but it gives feedback to us as teachers. How can we teach them differently so that more students can perform more consistently around what we're trying to teach. I've included in the bibliography, there was an excellent, very detailed report. So those of you who are really into feedback, Valerie Shute really wrote a wonderful report on formative feedback, very detailed, a lot of references for those of you who really want to get into the specifics. I highly recommend that particular report, and you should have availability of a copy of that. So back to this example. So some of the things that we use, as I mentioned, we start clinical training in year 1 because, as I mentioned, by the time our students need to enter clerkships in year 3, they already need to be very comfortable reporting out, doing their physical exams, working on a team, etc. So we start them right from year 1. And how do we do that? We also have a problem with not having enough there are never enough faculty. Faculty, particularly clinical faculty, are so busy. So what do? We actually use our technology quite a bit. So there's a lot of information online. Students, we train them to self-test. There are a lot of demonstrations, team learning. They give feedback to each other. They test each other. So a lot of peer-to-peer feedback, thinking out loud. So this problem solving, integrative problem solving, where we have them work in a group and actually explain their thinking to each other. And we find that really solidifies their learning, helps them remember without actually trying to memorize. So if they're learning through a case, learning through discussion, the retention is much better. Then by the time they work with a supervisor, they're already pretty good. And so your time as faculty is used much more efficiently. So you're not teaching the ABCs, you're actually seeing that they can read a sentence and actually are at a higher level than the ABCs. And that's worked quite well for us. We also use a lot of standardized patients in simulation all the way through, and that's part of the milestone checks. Because all of this is clinically applied, and if it's just a question and answer type test, that really does not translate to the ability to do patient care. So as much as possible, we try to use simulation, standardized patients, really mimicking the thought process they need to use clinically. And we have essentially 100% passage rate on the national exams. So the value of EPAs for clerkships, I think we can be confident that students will be able to participate in team care from year 1. They gain competencies each year with multiple competencies meeting 1 EPA. And the EPAs and the clerkships will then serve as a foundation to meet the core EPAs when they graduate in order to enter residency. And we're still a work in progress like every other school. But I have to say, I just happened to be speaking to one of our clinical faculty actually just last week, and he was saying he was really amazed at how our students were now performing with the new curriculum. He's been teaching for 30 years, and he has really noticed the difference in the preparation of our clerkship students. Very different level than what they were 10 years ago. So this example from Tufts' first year, the reason why I included this is just giving an example of how you can start integrating information from year one. So we actually took a focus group of physicians who are out in clinical practice, not at our main teaching hospital, but out in the community practicing in small clinics, who accept first-year students in their clinics. And we knew that this had to be a two-way street, because why would a clinical faculty want to take time out of their busy practice to teach our students? We figured if our students could actually provide some benefit, then they may be willing to accept the students in their clinic. And so we actually had them identify how they could be helpful, and then figured out those specific skills. Then we actually trained our students in things like taking a blood pressure, how do you, very simple things, introduce them to how the clinic works, having the students bring the patients into the room, weigh them, take their blood pressure, take their weight, start chatting with them a little bit, do a little patient education, et cetera, how to give a vaccination, very basic things that first-year students can do. Huge success, even more successful than we would have imagined. And the faculty were extremely pleased that these first-year students could contribute to team care. Good for the students, good for the clinics, and really helping our students get into the mindset of clinical care right from the start. So here, the reference that I gave here is from Professor Chen, developing EPAs for entry into a clerkship. And this is more for those of you who might be on the faculty planning groups that actually develop the EPAs.